Good afternoon, everybody. My name's Tracy Tyrrell. I'm Deputy Clinical Lead for Nottingham City ICP. So a really warm welcome to what is our final Share and Learn lesson today. Obviously, we will be having a second programme and we are just now starting to plan for that. But I'm really delighted that today we've got Dr. Margaret Abbott, who is going to talk to us about health inequalities. And Margaret is the City ICP Health Inequalities Clinical Lead. And we're going to follow the same format as previously, that if you want to post any questions, please do post them in the chat box and we will be looking at those, and we're going to have a presentation for around 20 minutes and then have 10 minutes with Margaret for questions and answers. So I'm going to hand over to Margaret. So welcome, Margaret.
Thank you, Tracy, it's a pleasure to be talking to people in Nottingham City this lunchtime. I come at this issue as a GP at the Windmill practice in Stenton for the last 32 years, and so I have a lot of experience of helping and supporting people who are living in one of the most deprived areas of the city. And I have been working also in the CCG in various roles for the last 10 years or so, and latterly for the last year as the Health Inequalities Clinical Lead. So I'm not a public health doctor, so I will be talking some basic information about health inequalities, but also personalising it with examples of a couple of typical patients who are experiencing health inequalities as well, and what we're doing in the city. As the ICP, we're a big partnership of many organisations, and working in the city, every single one of our organisations are dealing with people who are experiencing health inequalities, and so it's a really important topic that we all are aware of and that we are all trying to address. So, as I say, these are the things I'm going to be talking about. First of all, what do we mean by health inequalities? What are the causes? What are we doing in Nottingham City to address those health inequalities? And what more needs to be done in all our organisations in the city? And so the basic things about health inequalities is quite obvious, really. Health inequalities are the unfair and avoidable differences in health across the population and between different groups in society. So it affects how much ill health people experience, both mental and physical health, and also how long they might suffer from that ill health and whether they die at a younger age. And who experiences health inequalities? So there's been 4 different population groups nationally that are identified as experiencing health inequalities, and many people, particularly in city areas like ours, fall into more than one. So socioeconomic status and deprivation is the first and the one that we probably think most of about. Then there's protected characteristics: age, sex, race, sexual orientation and disability. And then there are particular vulnerable groups in society, vulnerable migrants such as asylum seekers, care leavers, traveller communities, homeless people, sex workers, for instance. And again, there's a lot of organisations in our city who are trying to support these particular vulnerable groups. And whether you live in an urban situation or a rural situation makes a difference, and there's different sorts of health inequalities in rural areas that we in the city might not be completely aware of, but they too may well have issues there. So I wanted to first of all, just as I said, personalise this a little bit, so that as we go through thinking about health inequalities, we actually have some people in mind. It's not just an abstract concept, health inequalities, it actually affects real people today. And so one person who I'm given the name of Precious to is this isn't a particular person, but it is a kind of amalgamation of many people that I've seen who have had this kind of experience. So we're looking at somebody who's Eritrean, single mother with a child, seeking asylum, come to Nottingham, knows no one. She's fled torture in her own country, but thinking she would come here and find that all is much better than what she's left, she finds that actually she's in poor housing, she's experiencing racism and abuse from her neighbours, she doesn't feel welcomed, she doesn't speak English, she's not allowed to work due to the immigration regulations, her income is absolutely minimal, and so she's suffering from mental health problems from her previous trauma, now feeling isolated, on minimal income and experiencing racism. She also has some physical problems. When she tries to access the hospital, she finds that she can't afford to ring to book an X-ray even, and she can't access an interpreter to ring the X-ray to book that anyway. So she does without investigations for her physical problems. And if she does have to go to the hospital, she has to walk there as she can't afford transport, and she has to bring her child along at the same time, so has to fit in with the routines of childcare. The second person I just wanted to kind of bring up was somebody who's more in a homeless situation. So this is, the typical story of many people I have seen over the last 30 years as a GP in Sneinton. We'll call him Jack, about 40. He's suffered adverse child experiences. His mother died, then he had abuse from his step family and went into care. So his school attendance is poor as a result of all those experiences, and he left without many qualifications and went into the army. He found the army quite supportive in terms of the environment and the support of his mates, but he experienced trauma from being on active service. He began to find that alcohol numbed his mental pain, and he treated that with treated his mental problems with alcohol. And when he left the army, he felt more isolated and adrift without the support of the army around him, until he became dependent on alcohol and failed to make rent payments and became homeless. He then became diabetic, which is not uncommon in people who have alcohol problems, but he had nowhere to store his insulin while sleeping on the streets, and he's often attending A&E either because of his diabetes, poor control, or because of the injuries he has when he's intoxicated. So sometimes our services can feel overwhelmed with people with all these multiple needs, and sometimes we can feel that we're blaming them for not attending appointments, for going to A&E more often. But if we think about what the background of these people might be, you can understand that there's many factors in the stories that I've just explained that might mean that they can't attend and access services or use them appropriately as somebody who is in stable accommodation and has had a stable background. So as we go through these next few minutes, I just want you to remember Precious and Jack as we think about what we're doing in the city. Deprivation doesn't just affect how you access services, but also affects the total length of life. Along the bottom of this graph, it shows the deprivation score. The higher score on the right is the most deprived, and the life expectancy, how long an average person lives. And the red dots are the 8 City of Nottingham primary care networks. And as you can see, they have people in those PCNs have an average life expectancy of that's shorter than those in Mid-Nots, which is the yellow orange kind of in the middle, or the South County areas, which is in the green. Again, this is a graph that shows the red city PCN population who have a healthy life expectancy lower than those. That means the amount of length of your life which is actually spent in good health. So when people start developing arthritis, diabetes, heart disease, how long is that? And people in the South County suburbs of Nottingham, have a much longer life without ill health than those in the city. And not only do people in deprived areas have a shorter life, they also have more. The number of health conditions each person has is higher. And this is a big study in Scotland, taking up the third of the population. And they found that in deprived populations, there were more long-term conditions and multimorbidity that started 10 to 15 years earlier. And in particular, the conditions of chronic pain, depression and heart disease were more common in those with living in deprived circumstances. So the average length of life is very different for different groups, and for a homeless person it can be a shocking 43 to 47 years of age of an average length of life, and people from different ethnic groups have different cardiovascular disease, diabetes incidence, as well as infant mortality. Care leavers are more likely to experience challenges with their mental and physical health, and people with severe mental illness or a learning disability have a life expectancy of 10 to 15 years shorter. But it's not just the actual, these people don't just have different conditions, it's the fact that the whole of their lives and circumstances are being affected. So this shows, which is quite a common thing that we talk about in relation to health inequalities, is that there are four main areas contributing to health inequalities, and the first of these, 30% of health inequalities, is down to health behaviours of individuals: smoking, diet, exercise, alcohol and poor sexual health. Socio-economic factors make up 40%. So this is very much education, employment, income, social support and community safety. Those wider parts of our society that are not in relation to direct relation to health, but actually are causing 40% of health inequalities. Clinical care, which is what the health service often concentrates on and tries to put most money into, is only makes up 20% of health inequalities. And access to care and quality of care is what the health services very much concentrate on. But it is very much a smaller proportion than all the rest. And then the built environment is 10%, which you might wonder how that affects health inequalities, but environmental quality, air pollution and so on, and the built environment, poor housing, do make up a total of 10% of health inequalities. And the two people that we've talked about suffer from very many of these things on this page here: education, employment, income, social support, environmental quality, built environment, as well as things that they've done themselves and started themselves, such as alcohol use. So very much the things that can affect somebody's health is very much related to not just health services, but very much the wider determinants of health is what they're called. So one of the things when we're talking about access to clinical care is we could look at the non-attendance rate. This perhaps shows how accessible are our services, and this just illustrates from local data what the issues are with accessing our secondary care hospitals. And as you can see on the right hand side, 4 of the 8 city PCNs actually have very high rates of non-attendance at the first outpatients. And so you can imagine that the two people that we've talked about, Precious and Jack, may well have a lot of reasons why they have difficulty attending outpatients. And if they don't attend the hospital for investigations and for consultations, their health is going to be poorer, because their health problems are going to be neglected and not properly treated. And so we need all of us at primary and secondary care level and community level in the health service to really be thinking, how can we make sure the access for all sorts of people is as good as possible? Otherwise, they will get their health conditions neglected. I will skip over these two, but these two slides are related to the effect of poor housing and poor conditions on our immune systems, which this is to do with a study a long time ago in relation to TB, and has very much a relevance today in terms of COVID. It's not just the infection that you get infected with that's a problem, but it's also how healthy you are in relation to your circumstances and housing. And then quickly there's a big study as well known to public health about access to green space and mortality from heart disease. And those living with more green space and nature around them have much less heart disease. And so that's an important aspect that we must not forget in all that we do. So what are we doing in Nottingham City to address these health inequalities? We've all got our priorities and we're trying to do our best for the client in front of us, but we get the outcomes that we measure. So it's very important that we commission services that really will address health inequalities. And Nottingham City is trying to concentrate on particular areas of work that will make a definite difference in relation to health inequalities. But it's really important that we work together. And it has been said it takes a village to raise a child, but it takes a wider society and health and social care partners working together to address those health inequalities that we were illustrated with Precious and Jack. So these are the list of the priorities work streams that the ICP has been doing, which many of you might have be aware of. We've got work streams in relation to severe multiple disadvantage, care leavers, smokers, flu vaccination uptake, and BME communities, and also working together across neighbourhoods in PCNs to link with local partners and look at the health and social care needs of the local populations. So they are specific work streams of the ICP, and we're very grateful that many organisations have come forward to actually work together on those. But wider, we've had there's a lot more going on, obviously, than just those work streams. And we're really fortunate that we've got a really forward-looking city council that has got positive policies on public transport, air pollution, housing and green spaces, and social care. We've got the large trust, hospital trusts, who have opportunities to support training and employment for local people. And we've got other organisations such as Small Steps, Big Changes, Opportunity Nottingham, the DWP and the CCG, as well as the Healthcare Trust, who over the last year to 18 months have all put new projects in place and funded new services so that people's health inequalities are addressed. And I'm very grateful for all of these people, all the work that they're doing. During the COVID pandemic, we've had various also local projects which I've been very privileged to actually be part of or be in the groups about, and we're very grateful for all those that have been working with the homeless, the asylum seekers, the shielding and vulnerable, and all those have come together to really help our population take up the COVID vaccination so that we can all be more healthy in the future. But there's new projects too on exercise, green social prescribing. GP practices are getting together to look at health inequalities and what they can do. And in 2021-22, we're hoping that there will be a mental health collaborative working on more mental health projects as well, which we're just starting in the last year. What more should we be doing? So, of course, much of this, and we are constrained by national policies, and we do need national policies that are effective, that address unemployment, housing, education, poverty, climate change. But when we look locally, we also need to be looking, as we have done during the COVID period, really looking at the data to see which people are really not taking up services or not accessing services. And we really need to be willing to look at this data and change long-standing thinking. For instance, have we ever looked at how many people are not attending our services, and what can we do to actually reduce that number of people who don't attend, and which people exactly aren't attending, and what adjustments do we need to make to actually improve that? So we all need to be looking at our process and policies on access, and ensure our staff in particular are enabled to deliver very personalised, holistic and compassionate care that then supports and empowers our citizens and patients. You can see from those two examples that I made, that Precious and Jack, that actually they needed some support to give them a lift up to actually access services and actually improve their lives. We need to work more across organisations, as I've mentioned, and our staff training needs to include awareness of different cultures and the effect of trauma, so that we are dealing with people in a compassionate and helpful way that's actually going to get people to where they need to be. And particularly during COVID, we found that working more closely with underserved communities and their leaders has been really helpful, and really so we're just at the start of doing that, but it's been a real privilege to see the work that underserved communities can if we come together, then we can understand better their needs. So just a final couple of slides. We should always be asking, what could we do differently, instead of why won't they change? And in terms of what I've experienced has happened to people such as Precious, is if they're supported by many different organisations, they actually can turn their lives around. So the Knots Refugee Forum, local charities, city care, interpreters, health visitors, asylum seeker health checks by the GP, and that all of those things can help people such as Precious to move on. But the key thing is that if she can speak English and she can start to work and she can move into better accommodation and she's linked with friends and community, then her physical and mental health will improve. And likewise with Jack, those homeless services that are linking with the people who have homelessness, and the alcohol services, the GP mental health referrals, and the housing department, and also British Legion, as he's an ex-forces person, all can link in to help Jack to actually turn his life around, and then can start to have regular diabetic checkups with a GP, no longer attending the A&E, and as we've put in place recently, able to have the COVID vaccination at the roving bus. So I thank you for your time today, and I hope you will think of Precious and Jack as you look at your services and think, can our services actually be adjusted so that people such as Precious and Jack can access them? But also we need to be working together on all those wider things that I've mentioned. So thank you very much.
Thanks, Margaret. Thanks for a great presentation, Margaret. So we've got lots of questions being posted, which is great. So I think firstly, just to acknowledge, people are acknowledging your personal role, Margaret, and just thanking you for all that you do. And there's some messages there in the chat just around your work ethic and your knowledge around health inequalities breathtaking, and that we need more of you. So I think if I just pull out some of the questions, Margaret. So the first one, from your presentation and other well-published evidence, it's clear that healthcare provision only impacts a relatively small proportion of a person's well-being. And I think that came through strongly in your presentation. So the questions around how can we work together more effectively as that ICP to impact upon all the non-health determinants of health inequality?
Yes, well, it's a very big question, isn't it? As I said, a lot of the impact is also national, isn't it? So, but we need to be making sure that we're supporting our city council in all their projects that they're trying to do, their public health department. Obviously, I'm not a public health doctor, but we need very much more public health input so that we really know which of the interventions that we're putting in place actually will give the most impact, given that we've got a limited budget, especially the city council. I realise that really they do need to we need to be directing us through their public health consultants as to which are the most effective things that we can do for our population, and very much support into employment, support with education and housing in particular are things that that are really important, and we need to make sure that we have advice places that people can go to make sure that they can access all the kind of additional things that will help them to actually get into those housing departments or into education and training.
Thanks, Margaret. So there's a question from some of our hospital colleagues. So if you were giving advice for hospital staff, what would be what are the best ways for hospital staff to help tackle inequalities? So what would be your top tips?
Well, the top tips, I think we need to be asking, as we move into a more online environment in terms of consultations being on the telephone, on the videos, and not just face to face. I think we have to be aware of the digital exclusion of many of the people living in deprived populations, and so I would be keen that when GPs are referring to the hospital, we should be putting on forms. Can this person access telephone, video, or do they need face-to-face consultations? Because it may be that they haven't got phone credit. It may be that they can't understand people when they're on a video or a telephone. We need to be actually thinking about that in the services that we offer. And then when we actually have people coming who have got mental health problems or severe social problems, then we need to be thinking, have they got extra support available in their social circle that can actually help them? And are we asking, is there anybody who actually could help you? So perhaps somebody else has got a phone, and the appointment could be made through that other person, or they might need somebody to actually accompany them to try and bring them there. The other thing is that people with severe mental illness or the kind of background that we're talking about in terms of Jack often feel very nervous about authority and can get irritated very quickly. They might have stopped drinking in order to come to the appointment, and they might feel quite irritated. So and easily be annoyed with people. The key thing is to keep people. It's a basic thing that when you go to the hospital, we really need to make sure that people are really informed about what's going on. We might feel embarrassed that actually we're running 20 minutes late, but people who, such as Precious or Jack, might have all sorts of other things on their minds and might become quite angry. But if you're explaining exactly why you're running late, and it's not that you're keeping them late, everybody's running late, so that they might feel more relaxed, and also they might have to leave in order to control their anger. But quite often we find that people get discharged and told they can't come back to the hospital just because they got annoyed because they weren't informed about what's happening. So it's really important that you look at each person and think, if I was in that position, would I feel annoyed? Can I preempt it by actually informing everybody what's happening to try and keep a calmer atmosphere and actually make adjustments for that person and say, would you like to wait outside or wait in a quiet area so that we can come and fetch you when needed? So it's just being basically understanding the background. And there is some training that's available. There's a fairhealth.org training, and there's also the PI and TIC, the psychologically informed environments, trauma informed care training, which is at pdu.org, which I would encourage staff and managers to kind of look into, so that we actually have a more compassionate and understanding workforce.
Thanks, Margaret. That's really great. So we've got many questions, but we're actually out of time. So thank you for a great session, Margaret. And yeah, brilliant. Thank you. So as I said at the beginning, this is in our first phase, the last share and learn. We will be starting again. So look out for the dates. We will be publishing all the first wave of our share and learn on Twitter, the ICP Twitter account. So do look for those and take a look at all of the sessions. But I think everybody will agree, a really great last session in this first phase. So a huge thanks to Margaret, and have a good afternoon, everybody. Thanks for joining.